Hey there, happy Friday. I apologize that our video is having trouble today on Facebook. And so I'm going to just check over here and see how we're doing. And it looks like we're getting video. I just can't see it myself. So I think we're good. So thanks for joining us this Friday. I am really excited for today because today's topic really came from a question that a student posed to me. They sent me a direct message or reactive a direct message on Instagram. And so, and something that just really jazzes me quite a bit is talking about cases and problem solving and figuring out what to do, especially when you look to the literature and evidence and there's not a lot out there. So it looks like we're going to be live here, so I apologize. I'm kind of checking our feed and make sure this is working, but it looks like it's working. So if you haven't been here before, I'm Julie Hirschberg. I'm the owner of Reactive Physical Therapy, and our mission is to help people with neurologic diagnosis recover their movement, their strength, their confidence, get their life back through brain-changing therapy and exercise. And we do this through physical therapy, occupational therapy, personal training, our group classes, and through education of other healthcare providers. So thank you so much for joining us. And I really have to thank our a student who contacted us, not one of our students actually. So this is a student that we have met through mutual friends, and she sent this message. And I'm just one of those very curious people that asks a lot of questions. So I love when other really curious people send me questions. And I love to dive deeply into understanding things. So I want to read to you the question. So I love following your content and the progress your team makes. I'm currently working in an outpatient neuro clinic in a rural town that sees a variety of cases. I'm struggling in treating focal limb dystonia in the lower extremity. At least 3 of my patients are presenting with this, and I haven't found sufficient evidence on treatment ideas. Would someone at Reactive be willing to do a feature or talk on sharing treatment or strategies to address lower limb dystonia? Well, yes, I would, and thank you very much. And so she goes on. Because I was like, well, what's causing the dystonia? Because that makes a big difference in the treatment. And so she says the causes are varied, but the presentation is similar. One is for a patient with a, quote, walking disorder. This sounds a little bit more like a functional movement disorder. Another is a patient with cortical basal degeneration. And the third is somebody with a Parkinson's-like presentation. So also might be a Parkinson's plus. So I was really excited to get this question, to be honest. I feel like this is something we deal with a lot. And so today what I want to talk about really to answer this question are what are some of those causes of lower limb dystonia and how you might deal with them differently. Certainly the prognosis is going to be different. And in particular, we'll talk about the Parkinsonisms and functional movement disorder presentation because they're very different. And the evidence is very small. There's, in the literature, mostly just case studies looking at treatment in focal lower extremity dystonia. So we'll talk briefly about this, but mostly I want to just brainstorm some ideas to get her started. So let's talk about the 2 cases that might be the Parkinsonism, and in particular, cortical basal degeneration. It actually is the most common cause of dystonia in the Parkinsonism syndromes is cortical basal degeneration. It's definitely what I've seen the most. It's what's in the literature, and can be in the upper or lower extremity and present various ways. So I think one of the big pieces here is we want to see if it responds to medication. So certainly that's a medical management piece of it. And the second piece here that I found, so there's actually not literature in this area of physical therapy management in cortical basal degeneration, but what I have found to be helpful and successful for people is forced use. So especially in the lower extremity, forced weight bearing, and doing that in thousands of different ways. So, for example, depending on the person's ability and function, could they do it with weight bearing on one lower extremity while the other extremity is doing another task, like tapping, like stepping up, kicking a ball, all of those things. So they're weight bearing and having that normal sensory experience through the lower extremity. And if it looks like I'm distracted, I totally am, because my dog is barking and I can actually see that my door is open here. So I'm going to close it really quick. Maybe you have joined me before when our dogs are barking. I'm not usually at home because dogs might be barking. We have a puppy too. So he's probably hearing me talking and hearing me get excited, because I get excited about these things. And he's like, well, let me join in. So I apologize for that. So we were talking about specifically treatment ideas in the Parkinsonism. So number one, finding out and having that definitive diagnosis, looking at the medical management, and this can be medication changes and the use of Botox potentially. And there is literature to support that in Parkinson's and in the Parkinsonism. So so that's very important conversations with a physician to get that piece understood and attack that as well. So when it comes to our PT treatment, what we're talking about forced use in 1,000 different ways, weight bearing as much as possible. And this can be really challenging when the person has balance problems. And so now they're using an assistive device and now they're having less weight on their lower extremities. Oh my goodness. Now the other dog is barking. This is just a tough day for a Facebook Live. Let me let the other dog out. Okay, so Noreen, this answer is for you, and I apologize for all the dog interruptions. What a crazy day. So let's talk about ways that we might do a forced use as well. So one of the things you had actually asked me to was weighting the limbs, and I think that's a really great idea because it drives the forced use of that limb as well. And thinking about ways, especially using external cues, that you may alter the mechanics of the opposite limb so that you can drive use in that limb. So one of my favorites is not just saying take a longer step, but actually having somebody hit with their heel out on the other side to really force loading in the more involved extremity, the dystonic extremity, and forward progression over that extremity. And I like to use an external cue. So maybe a piece of tape on the heel and say, hit really firmly that piece of tape on the ground when you take a step with the opposite side, and see how that might change the gait mechanics. So those are just a couple of ideas for forcing the use when there is lower extremity dystonia that's due to a Parkinsonism. So one little thought there. We'll talk about a couple other things in Parkinson's disease as well. So the second is a functional dystonia. And I think what's important here is to know whether it's truly functional. So if it is, it would be usually a sudden onset, more atypical and variable durations of attacks. There might be an injury that preceded it. So these would be the questions I'd be asking yourself and the person you're working with to kind of distinguish this. Symptoms that are varying and unpredictable across time, symptoms that are lessened with distraction. So this would be something in particular that you would do within your session to see if that changes, and then that actually becomes part of treatment as well. Spontaneous remissions and relapses, abnormal movements or pains that are inconsistent with maybe a physical impairment, increase in the symptoms with exposure to psychological stressors. However, I would say that's the case for most things. And maybe other additional symptoms that aren't really explained by a diagnosis. So those would be things to really ask yourself, ask the person to make sure this is truly a functional dystonia. So I'd be really curious about that. And then when it comes to the functional movement disorder, or if it truly is idiopathic dystonia, or maybe has a bit of both, those principles of learning-based sensory motor training that are in the literature, in particular for hand dystonia, but have been implied in the lower extremity. So there are some case series, especially for runner's dystonia, that I would say would apply to it happening in walking as well. But those principles of preparing the brain, training the brain, and making sure to address underlying contributing factors. So preparing the brain, I would first assess the autonomic nervous system and then treat at that level. My favorite, and we just did this today with a person with cervical dystonia, is the extended exhale. So the inhale for 2, exhale for 4, seeing if the dystonia responds to that. I love doing it while walking as well. So that's a really nice one that will work and that be helpful if the autonomic nervous system, if the sympathetic drive is a little high. So that's one thing that I would try from the preparation part. I really love rocking movements and standing for that weight shift. So dancing is a lovely technique for that. That also tones the nervous system with rocking movements and prepares the brain. Imagining movements and mental imagery also helps in that prepare the brain part. And then using the Recognize app to test laterality. So in particular for the feet in this case, so use that to test it and then use it to treat it. So seeing if they have some body perception awareness issues and treating those as well. So those would all kind of fit in that category. In the training side, we want to practice as much as possible outside of that dystonic movement. So that would include things like mirror therapy. That would include things like practicing with external cues. So if the person is moving into plantar flexion and eversion, putting that piece of tape on the toe of the shoe or a bell on the toe of the shoe and asking the person to lift that up versus just lifting their foot up. So using external cues and techniques like that, those types of things tend to help both a functional dystonia as well as an idiopathic dystonia. So I think you would benefit really from trying both of those types of things. And then there are myriad ways to do that on the treadmill with playing cards that you have to step over. I really love the treadmill because it forces a step as well. I like using noodles and boxes, and we have these things called river stones, so stepping over and in different directions. And if it is more functional, actually taking out the self-awareness. So what I've seen in a functional movement disorder is if you put more emphasis on their self-awareness of that limb, like overemphasizing it, it actually can make it worse. And that's where the external cues allow a more automatic movement to emerge. So that would be really helpful in the case of a functional dystonia. Typically, immobilizing the joints with a cast or splint is not helpful. And doing passive stretches, unless of course there is some muscle limitation, but passive stretches or very like move your toe this way, those are those self-focused things that can actually make it worse. But the external cues and then those really nice enhanced expectation, providing choice and autonomy, all those pieces of the optimal theory can be very beneficial if it's a functional dystonia. And again, the literature in the functional movement disorders is really very much an emerging area and growing. In lower limb dystonia, it is mostly based on some case series in the lower limb, but there's a lot of really nice studies in the upper extremity that I think the principles really apply. The paper I love the most is the Bill McKinsey Learning-Based Sensory Motor Training article from 2008. It is in the upper extremity, but have a really nice review of those key components of it. So I think that kind of research, why it's not very specific to this case, the principles are very applicable. And let me know if you need help to access that article. I can help you get there. So I want to give one case example, and this is an example I shared before of a woman with Parkinson's disease who had some lower extremity dystonia. So this was not a Parkinsonism, actually. This was Parkinson's disease. And there were several pieces that through examination, I could find that there were difficulties in some of the sensory processing and awareness and body awareness, some difficulty on different surfaces and some stiffness, and some of the postural writing reactions being a little delayed. And those are some things that we can see in idiopathic dystonia as well. And some of the things that we had to do were make sure we addressed underlying issues. So biomechanical issues, sensory issues, balance, and certainly nervous system regulation was another thing. So all of this dystonia got worse with anxiety and stress. So that's where doing things like the extended exhale were really helpful. Providing joint mobility if needed, increasing weight bearing on the limb, as we mentioned. We did a lot of things with eyes closed on different surfaces and worked on discrimination, sensory discrimination in the feet. So overall activity level, so this is really what hit it home for this woman with Parkinson, is that she had decreased her activity overall on her legs because she was a little less confident in her walking. And so we worked on building that up so that she could be walking more for both aerobic and just overall physical activity. So she had things like you mentioned in your patient. She had some toe drag, she had foot drops, some hyperextension sometimes, and overall underuse of that side. So we did things like using those half body glasses, things with her eyes closed, lots of different surfaces to rebuild her sensory awareness. We added head turns and trunk rotations and dual tasks to that for her. But once she started adding back in her overall walking routine, the dystonia started diminishing. So no more foot drop, toe drag, hyperextension. And she also didn't have to change her medications or Botox or get DBS. It was just that increase in physical activity with the forced use component. So that was somebody with Parkinson's disease. The prognosis for that is not as good in cortical basal degeneration, but I do think that you'll find some improvements with forced use, and actually that you can maintain that function for longer. And similar, if it's a functional dystonia, providing that increased activity level with those external cues, I think would be very helpful. So that's 3 cases, all a little different for sure, all take different techniques, actually have different prognosis as well. I think the prognosis for your case was somebody where it might be a blend of functional and idiopathic that might actually have the best prognosis for you. And I'm really excited to hear how they do. I see a comment here from Jen. She says, hi, and thanks for checking in today. So I want to provide you all a resource. So we have a Dystonia Program handout. I just used it yesterday in an evaluation, actually. And it goes through the pieces of the evaluation and the treatment that include the sensory, the motor, the autonomic, the lifestyle factors that are all important in the management. So I would invite you to grab that. It's actually on our education page, reactivept.com/education. And if you love this kind of problem solving, patient specific, case specific problem solving, I'd love for you to join us, send questions for sure, and look out in the next month. We are actually going to launch for just a few people a beta test of a group that's just going to do that, actually do some patient case problem solving together with some experts in the field. So if you're interested in that, definitely sign up on the interest list on our education page, and we will stay tuned. So thanks so much for joining us today, despite all the video issues and the dog issues, and we will see you next time.